should, I can give you an introduction to one role model. And that's our chairman, Professor Mufti. He doesn't need to be here. He perhaps knows more than what I know and what I'm going to tell or what the other speakers are going to tell. But he has this immense love and lust for knowledge that he wakes up early in the morning and comes and attends the session at his age and stage. That's only the love and lust. And then, if you are looking for role models, here's a living example. So with the permission of the chair, my task in this session is to talk about the International Prevalence and Treatment of Diabetes and Depression program, and from that a small component in terms of the primary healthcare perspective. Those of you who've been here through this conference, you would have seen that I have begun to talk about the primary healthcare. Either it is the training and the recognition of the psychiatric disorders, or it is a program launched for the services of the patient, or we are talking about research. We are looking at the primary care level, because in a tertiary care level, where we have worked all our life, we only see a segment of population that comes to us. Our masses are in primary care. And if we want to do something good for the good of this nation, I think we should never ignore primary health care, and that's a message that is going to reflect through the project that I'm going to be talking to you about. Now, the outline that I've set my slides in, rather my registrar, Dr. Zaidan, has been helping me out throughout the presentation, and he has learned quite a lot about what this initiative is all about. And he said to me, "Sir, describe your presentation in terms of the comorbidities, then talk about the depression and diabetes, and then come on to talk about the study that we're going to do in the primary care." Now, you will see that as a psychiatrist with over 30 years of working experience, gone are the days when I get a patient who has only psychiatric disorder. It is always a combination of any comorbid physical, medical disorders that we deal with. And when such like occasions happen, you and I need to understand that diabetes is one which is very common disorder in our country. And I'll tell you some more some more statistics as we go along. When these two disorders happen together, we think that the functional impairment is more than when depression happens alone. And when somebody suffers from a comorbid condition like depression and diabetes, the problem is adherence. We have heard in the session already that people don't comply with medication. It was Professor Imtiaz Dogar who was talking about the outcome of the treatment that people are taking, and he mentioned that out of 100 patients that you prescribe antidepressant treatments, only about 30% people will take those antidepressant medication. And if that combination is that there is a comorbid condition, this adherence is going to go down further, which would complicate our problems, because diabetes is not going to be treated and depression is going to get worsened without the treatment. We also have some evidence, and I'll present some scientific basis for that, that the physical symptoms get amplified when these comorbid conditions happen together. Also, depression has a mortality of its own, but depression combined with physical disorders like diabetes, this mortality staggers up. And last but not the least is the cost. If your treatment doesn't succeed after the patient comes to you, I think you are partly responsible why that treatment is not working. And that would cost the patient and the family a lot more money than he can afford to give. This again is a slide that amplifies my point by saying that depression is comorbid with so many other physical disorders, and I'm not going to take you through one by one, but you can see at the bottom, when you have Parkinsonism, more than 50% of patients with Parkinsonism are going to have depression. And the list of the other things are given there. Now, I'd like to point out your attention to this monumental study that was done the world over by Musavi and his colleagues. Psychiatrists have been trying to measure the burden of diseases by many parameters. They looked at the quality of life, they looked at the disability-adjusted life years, and in this study, which was carried out in 60 countries with more than 240,000 people, Musavi et al. Used what they call as a mean health score. They calculated the health scores of all physical disorders alone, and they calculated the physical and the health scores of the comorbid depression and diabetes, depression and hypertension, depression and cardiovascular diseases. And this is a graph which may be a little difficult to understand because my graphic sense wasn't able to give me the clarity in that. But these are the findings of that study that you need to know. That depression had the largest effect on worsening mean health scores compared with other chronic conditions. Depression produced the greatest detriment in health compared with the chronic diseases angina, arthritis, asthma, and diabetes. The comorbid state of depression incrementally worsens health compared with depression alone, with any of the chronic diseases alone, and with any combination of chronic disease without depression. So with this, you would know that the combination is a disastrous combination in terms of the mean health scores. Now, this is a slide which will talk about what is the mechanism of depression and the medical comorbidity. The hypotheses are given here that it can be an independent phenomena, or it can be precipitated by the stress of medical conditions, or the medical conditions precede depression and is felt to have a pathophysiological effect, or it can be a substance-induced response. And lastly, people have hypothesized that depressive symptoms are a normal response to being severely ill. After all, when you diagnose a patient to be suffering from diabetes, have you ever heard what happens to that patient? I went for my cardiac checkup, and I was sitting with this renowned cardiologist in the Twin Cities of Rawalpindi, Islamabad. A patient came in who had his angiography done and all the workup for the cardiovascular disorder. The cardiologist looks at the report and says, well, your 3 vessels are blocked. I don't think I can do anything for you. Now I'm referring you to the cardiac surgeon. You please go and God be with you. That's the information that the cardiologist gave to this patient who was 45 years of age. And I was sitting there as a patient myself, and I just looked at the expressions on the patient's face. I think he understood nothing what would happen to him after he goes out of that doctor's office. Because the psychology would start to go wrong. And when the psychology starts to go wrong, symptoms of